Neuroendocrine neoplasms represent one of the most challenging areas in pathology due to complex and often inconsistent terminology and classification systems. The confusion begins with differences across organ systems. For example, in the lung, neuroendocrine tumors are categorized as typical carcinoid, atypical carcinoid, and neuroendocrine carcinoma. In contrast, other organ systems, such as the gastrointestinal tract and pancreas, use the terms neuroendocrine tumor and neuroendocrine carcinoma, with neuroendocrine tumors further graded as grade 1, 2, or 3. Distinguishing a well-differentiated grade 3 neuroendocrine tumor from a poorly differentiated neuroendocrine carcinoma remains a significant diagnostic challenge for many pathologists. To add to the complexity, there are also entities such as carcinomas with neuroendocrine morphology and carcinomas with neuroendocrine differentiation, which further blur diagnostic and therapeutic boundaries. This evolving and sometimes inconsistent nomenclature creates confusion not only for pathologists but also for clinicians, raising critical questions about appropriate patient management. How should we treat tumors that fall into these overlapping or poorly defined categories? Clearer diagnostic criteria and consensus in classification are urgently needed to guide therapy and improve outcomes. First, let's examine a figure from the article. It shows a typical basal cell carcinoma that is diffusely positive for the neuroendocrine markers, chromogranin, and CD56. The authors interpret these findings as indicative of basal cell carcinoma with neuroendocrine differentiation. But does such an entity exist? Basal cell carcinoma with neuroendocrine differentiation? Probably not. In fact, approximately 50% of basal cell carcinomas show positivity for chromogranin, often with strong and diffuse staining. This is a well-documented, non-specific finding in BCC and should not be interpreted as evidence of true neuroendocrine differentiation. Contrary to the author's conclusion, these immunohistochemical results likely reflect a known feature of BCC rather than a distinct variant with neuroendocrine differentiation. It is also well established that in the lung, approximately 10 to 20% of squamous cell carcinomas and adenocarcinomas can express neuroendocrine markers when tested. Therefore, to avoid diagnostic confusion and potential misclassification, it is generally not recommended to perform neuroendocrine immunostains in the absence of characteristic neuroendocrine morphology. Let's look at another example. These images are taken from Dr. Epstein's book Biopsy Interpretation of the Prostate. The case shows a high-grade prostatic adenocarcinoma with a Gleason score of 5, demonstrating a sheet-like growth pattern and prominent nucleoli, features consistent with conventional high-grade adenocarcinoma. Importantly, there is no neuroendocrine morphology. Immunohistochemically, NKX3.1 is diffusely and strongly positive as seen in the usual type prostatic adenocarcinoma. However, a subset of tumor cells also shows strong positivity for chromogranin. So, how should this tumor be classified? This is a classic example illustrating why neuroendocrine markers should not be performed in the absence of neuroendocrine morphology. Routine use of neuroendocrine markers in typical prostate adenocarcinoma is not recommended, as it may lead to diagnostic confusion. If neuroendocrine immunostains are performed and show positivity, the tumor should not be diagnosed as prostatic adenocarcinoma with neuroendocrine differentiation. This distinction is critical, as the phrase neuroendocrine differentiation is often interpreted by clinicians as indicating small cell carcinoma, which has very different clinical implications and management. The critical question is, what is neuroendocrine morphology? Neuroendocrine morphology refers to distinct architectural growth patterns. The four classic patterns are organoid nesting, trabecular growth, rosette formation, and peripheral palisading. Tumor cells typically exhibit round nuclei, finely granular salt and pepper chromatin, and inconspicuous nucleoli. However, cytologic features can vary, particularly in large cell neuroendocrine carcinomas, where prominent nucleoli are often seen. Therefore, in routine diagnostic practice, when we refer to neuroendocrine morphology, we are primarily referencing these four architectural patterns: organoid nesting, trabecular growth, rosette formation, and peripheral palisading. It's important to keep in mind that the diagnosis of small cell carcinoma is primarily based on cytologic features rather than architectural patterns. While the growth pattern can be variable, as shown in this images, we see single cells, irregular nests. Here we see sheet-like growth pattern. Some small cell carcinoma may also occasionally exhibit classic neuroendocrine architecture such as organoid nesting and peripheral palisading. Crush artifact is another morphologic clue, particularly in small biopsies. This is due to the fragility of the cellular and nuclear membranes, which makes the cells highly susceptible to mechanical damage during tissue processing. The hallmark of small cell carcinoma lies in its cytologic characteristics, an extremely high nuclear to cytoplasmic ratio, nuclear molding, very fine chromatin, absent or inconspicuous nucleoli, and a very high mitotic and apoptotic rate. To summarize, neuroendocrine morphology refers to four characteristic architectural patterns: organoid nesting, trabecular growth, rosette formation, and peripheral palisading, as well as the distinctive cytologic features of small cell carcinoma. When neuroendocrine morphology is present, we can do neuroendocrine markers to confirm neuroendocrine diagnosis. Neuroendocrine markers include synaptophysin, chromogranin, CD56, and the more recently introduced nuclear marker INSM1. However, none of these markers are sensitive or specific. Approximately 10 to 20% of pulmonary small cell carcinomas may be negative for all of these markers. Conversely, many non-neuroendocrine tumors can express one or more of them, further complicating the diagnostic landscape. Here are pictures of positive neuroendocrine marker stains. INSM1 is a nuclear marker. Synaptophysin and chromogranin are cytoplasmic markers, while CD56, not shown here, stains cell membrane. INSM1 is a nuclear marker that has gained significant attention in recent years. Early studies suggested that it is both sensitive and specific for neuroendocrine tumors, with some even proposing that INSM1 could be used as a standalone marker for their diagnosis. However, in practice, INSM1 is neither entirely sensitive nor specific, and the diagnosis of neuroendocrine tumors remains challenging, still relying heavily on morphologic assessment. One particularly important study highlights that INSM1 is frequently expressed in HPV-related oropharyngeal squamous cell carcinoma. This finding is clinically significant, as distinguishing between squamous cell carcinoma and high-grade neuroendocrine carcinoma is critical due to their markedly different clinical behavior, treatment strategies, and prognosis. HPV-positive oropharyngeal squamous cell carcinoma is well known for its favorable response to treatment and excellent prognosis, with a 5-year survival rate exceeding 90%. In contrast, HPV-positive high-grade neuroendocrine carcinoma of the oropharynx carries a dismal prognosis, with median survival measured in months. These tumors also differ significantly in treatment approach. High-grade neuroendocrine carcinomas typically require aggressive multimodal therapy, while HPV-positive squamous cell carcinomas are often eligible for de-escalated chemoradiation protocols. Therefore, accurately distinguishing between these two entities is clinically critical, as misclassification can lead to inappropriate treatment decisions with potentially devastating consequences. Shown here are two examples of HPV-positive high-grade neuroendocrine carcinoma of the oropharynx. The image on the left demonstrates small cell carcinoma, while the image on the right shows large cell neuroendocrine carcinoma. Both tumors are positive for cytokeratin, synaptophysin, and chromogranin. The Ki67 labeling index is very high, exceeding 90%. P16 is diffusely positive in the tumor cells, and in situ hybridization confirms the presence of high-risk HPV. It is well recognized that basaloid squamous cell carcinoma can morphologically mimic high-grade neuroendocrine carcinoma. As illustrated in this image, it may exhibit a nested growth pattern with vague peripheral palisading. However, the tumor cells are diffusely positive for P40, a marker typically not expressed in neuroendocrine tumors, supporting squamous differentiation. INSM1 shows weak, focal positivity, a staining pattern that can be seen in various non-neuroendocrine tumors. Such staining should not be misinterpreted as evidence of true neuroendocrine differentiation. Additionally, INSM1 can show strong, diffuse nuclear positivity in a subset of squamous cell carcinomas, as demonstrated in this case. The H&E image reveals a typical basaloid squamous cell carcinoma, and immunostaining for P40 is diffusely positive, confirming squamous differentiation. However, INSM1 is also strongly positive in approximately 20 to 30% of tumor cells. It is important to emphasize that ISNM1 positive staining alone does not indicate true neuroendocrine differentiation or transformation. How do we diagnose HPV positive high-grade neuroendocrine carcinoma? First and foremost, the tumor must demonstrate neuroendocrine morphology. Additionally, there should be diminished or absent P40 expression, accompanied by positive staining for neuroendocrine markers such as synaptophysin and chromogranin. Given the significant clinical implications of diagnosing HPV-positive high-grade neuroendocrine carcinoma, it is essential to apply strict and rigorous diagnostic criteria. We have now discussed neuroendocrine morphology and the appropriate use of neuroendocrine markers. Next, let's focus on the diagnosis of metastatic neuroendocrine tumors. If a patient with no prior history of cancer presents with multiple nodules, and a biopsy of one of these nodules reveals a metastatic low-grade neuroendocrine tumor, what should be the next step? Should we perform immunostains such as TTF1, CDX2, NKX3.1, GATA3, and others to determine whether the tumor originates from the lung, gastrointestinal tract, prostate, or another organ? What if the tumor is a high-grade neuroendocrine tumor? Should we perform immunostains to try to identify the primary site? The answers to these questions are not straightforward. It largely depends on the tumor grade. Neuroendocrine tumors are broadly classified into low-grade and high-grade categories. High-grade tumors, such as small cell carcinoma and large cell neuroendocrine carcinoma, are aggressive neoplasms associated with poor prognosis. For high-grade neuroendocrine carcinomas, determining the site of origin is essentially impossible. These tumors are genetically unstable. One study demonstrated that, on average, high-grade neuroendocrine carcinomas express 8 different transcription factors. As a result, it is not uncommon to see simultaneous expression of markers such as TTF1, CDX2, and GATA3 within the same tumor, making it impossible to pinpoint the primary site. In addition, high-grade neuroendocrine carcinomas frequently lose expression of organ-specific transcription factors. For example, studies have shown that only 24% of endometrial high-grade neuroendocrine carcinomas express PAX8, and similarly, just 25% of prostatic small cell carcinomas are positive for NKX3.1. This further underscores the difficulty in determining the site of origin based on immunohistochemistry alone. Therefore, the primary site of high-grade neuroendocrine carcinoma often cannot be determined by pathology alone. Moreover, since the majority of these cases present at an advanced stage, identifying the site of origin typically does not impact treatment decisions or alter the prognosis. What about low-grade neuroendocrine tumor? Is identifying the primary site necessary in these cases? The short answer is yes. Identifying the primary site is important for low-grade neuroendocrine tumors. Surgical planning and chemotherapy regimens differ significantly depending on the site of origin, such as lung, small bowel, or pancreas. Immunohistochemical staining plays some role in helping to determine the site of origin for low-grade neuroendocrine tumors. TTF1 is expressed in approximately 50% of pulmonary carcinoid tumors. It is also not entirely specific, as it can also be seen in laryngeal carcinoids. CDX2 and ISL1 have been reported as relatively sensitive and specific markers for intestinal and pancreatic neuroendocrine tumors, respectively. Overall, immunohistochemistry can help assign the tumor's origin in approximately 75 to 85% of cases. Fortunately, we have additional tools beyond immunohistochemistry to help identify the primary site. Imaging studies are often very helpful in locating the origin of metastatic neuroendocrine tumors. Clinical presentation can also offer important clues. Lung carcinoid tumors and atypical carcinoid frequently metastasize to the bone and brain, whereas these sites are uncommon for gastrointestinal neuroendocrine tumors. Therefore, in low-grade neuroendocrine tumors, immunohistochemical stains can be useful in suggesting the primary site. However, these results must be interpreted with caution. Correlation with clinical findings and imaging is essential to ensure accurate diagnosis and avoid misclassification.